Hello, and thank you for joining us today. I'm Shelley Nasso, CEO of the National Coalition for Cancer Survivorship. Before we get started, I want to thank our sponsors. Pfizer is our presenting sponsor, and also AbbVie and Pharma have supported this webinar. And I also want to thank the NCCS team for helping us develop all the content and promoting this webinar. We really appreciate everybody's support in pulling this together. We all know how important insurance coverage is to managing cancer treatment and post-treatment care. And we're entering the season in which individuals choose their health plans, whether they're Medicare beneficiaries, they select plans through the Affordable Care Act's health insurance marketplaces, or obtain insurance through their employer, including the federal government. The array of options can be daunting, and it's essential that consumers do their research to choose the best plans to meet their needs. Cancer survivors have significant cancer care needs that will influence their insurance coverage requirements. A survivor in active treatment may need to consider whether their insurance plan covers the cancer care specialist they are relying on and has affordable and adequate coverage of the drugs that are part of their treatment plan. Survivors thriving after cancer treatment also have specific follow-up care and monitoring needs. Today, we want to help cancer survivors define their care needs and evaluate their insurance plan options for coverage and payment of their care. We're joined today by experts who will provide guidance on how to assess the adequacy of available insurance options for cancer care coverage and according to a cancer survivor's treatment and survivorship plans. Today, we're going to talk specifically about Medicare and Medicare Advantage plans, as well as the Medicare Part D and Medigap. But we also have additional resources on our website, including interviews with experts who provide advice on choosing employer-sponsored plans, ACA marketplace plans, and federal employee benefit plans. I'm joined today by three people with both policy and real-world expertise in selecting health plans. María Lopez is professor and vice chair of medical oncology at Sidney Kimmel Medical College and chief of cancer services at Sidney Kimmel Cancer Center. And most importantly to us, she is on the board of NCCS, and we're grateful to her for joining us today. Tricia Neuman is a senior vice president of KFF and executive director of its program on Medicare policy. Pollitz recently retired from KFF, where she was co-director of the Program for Patient and Consumer Protections in Health Insurance. So you can submit questions using the Q&A button, and I'm going to ask each of them to give some opening comments, and then we'll move to Q&A. We got some great questions from people who registered, and we know people have some excellent questions that we will try to get to as many of them as we can. So we'll start by asking Dr. Lopez to share some comments.
Thank you. Thank you. And so look forward to today's panel. So I'm an oncologist, as was mentioned, and I see, so I'm sharing more as a witness, the complexities of the cancer diagnosis and the complexity of trying to navigate that care. So we all know, right, in our health system, you got to have health insurance if you want to get health care, if you need health care, which we all do. So often when we're looking for insurance, we don't so much look at the fine print, but we look at the costs, and we kind of make those decisions often based on the least cost. So it's not uncommon, in my experience, that when illness comes, people may not know what their coverage is. They may not know how to access the care, and that's complex. Cancer, we know, does increase with age, so the incidence increases with age, and so then we think, oh, well, but there's Medicare, and so that must make it much easier, must make it more transparent. But often, for many people, it remains murky. Plans really differ, networks change. People can go to one place for some services, but they have to go somewhere else for something else. So it is confusing, as Shelley was saying. And something that I find especially frustrating, because when people are on treatment, laboratory results, imaging results are so critical. And when people have to go to different places and then I have to go to dig up those results, that can be very difficult. And especially then if things have to be redone, or, because it wasn't quite right, then that really creates a lot of difficulties. So it ain't easy. And it's hard for patients, it's hard for families, it's hard for us. I feel like it's kind of a shell game. So I just have a few questions for people to think about. So perhaps just at the beginning, as you're looking, are your doctors in the plan? If they're not in the plan, who are the new doctors? And even if your doctors are in the plan, it may not be the same ease of accessing as it was before. If you need more than your doctor, what is your access to specialty care? What is your access to hospital, to rehab, to different services? And how easy is it to get those coverage? You know, all of those issues of pre-authorization may differ as you go from plan to plan. Uh, there may be costs beyond the monthly premium, the co-pays, the deductibles, the out-of-pocket maximums. And when people are in treatment, again, all of those I think are important, but maybe also really looking at specialty care. What sort of specialty docs? Where are they? How accessible? I find accessibility is really important. And that's beyond, you know, the access related to costs. You know, yes, there may be cardiologists. We have a whole field of cardio oncology now. But if it takes 9 months to get in, that's not very accessible. What about clinical trials? Are clinical trials covered? How accessible? What sort of approvals need to happen before you go there? If you are hospitalized, will it be the same doctors that take care of you? How will that communication take place? Because maybe both hospitals have the same EHR, so to speak, but it may be a different format. So they may not really be able to speak to each other. So how do you have that communication? So in a way, the patient may be the carrier of that information from place to place. And is there a way to know how much administrative burden there is to the clinical team? Because that may limit the people that are on the plan. After treatment, survivorship needs are critical. What does survivorship coverage mean for that plan? Is it for a certain period of time? You know, I have patients who are like, oh yeah, I could see you in survivorship, which is defined as 3 months after. That's kind of shocking. Survivorship is forever. So what does survivorship care mean? And for how long will it be covered? Does it mean I stay with my doctor, or does it mean, oh, you'll get transitioned here? And do you know where here is and what that means? And do you get to, how do you get to work with them? Are specific screening tests, genetic tests, are all of those going to be covered as part of your care and part of survivorship? Post-treatment meds, is that again considered part of your treatment? Again, maybe your chemo or the direct, let's say the pills that you would be taking afterwards are covered, but the complications, maybe the cardiac meds, you know, maybe that's considered differently. And again, to think about the pre-authorization process, the imaging follow-ups, and are you able to stay with the same center? So a lot of questions, but I think it's important to have questions. And now we'll turn to the experts with some answers. Thank you.
Thank you. Now we'll go to Tricia.
Well, Dr. Lopez has just raised so many questions that give me, as a so-called expert, a headache in trying to think about what this actually would mean for anybody to try to answer these questions when choosing a plan or working their system. So I want to start by thanking you, Shelley, for convening this webinar, which is so important and matters to any one of us who, I don't happen to be a cancer survivor, but both of my sisters had cancer, as I think you know, and I'm very familiar with the importance of good coverage. I also want to say how happy I am to be on a panel with my former colleague and friend, Pollitz, and it's an honor to be with you, Dr. Lopez. Okay, so today is the start of the Medicare open enrollment period. So it's game day for Medicare, so very important time. The Medicare open enrollment period runs from October 15th through December 7th. So this is a time that matters for all beneficiaries, people on Medicare, to make a decision about the kind of coverage they want And if choosing between, say, traditional Medicare and Medicare Advantage, if people choose traditional Medicare, they have a choice of Medigap policies, they have all Part D plans to choose from. And if they prefer Medicare Advantage, they have a choice of dozens of Medicare Advantage plans. We just heard how the incidence of cancer increases with age, and people are diagnosed more at older ages. So this is a serious question for people with Medicare. As a really, I mean, insurance matters to everyone, but for people diagnosed or living with cancer or surviving cancer, it's particularly important. And when people are diagnosed, treatment is the first thing they think about. Getting well is the first thing they think about, not what kind of insurance they have. But I guess an important lesson I have learned is when making a decision about insurance, make the decision thinking about what do I want, what will I need if I get sick, rather than what do I happen to need right now. And so many people on Medicare make these decisions when they first turn 65 or when they first go on Medicare, which may be a little bit later. And that is when people are at their healthiest in the aging spectrum. And these decisions are not easy. I have my own list of things for consumers to think about, and that I haven't even scratched the surface of what Dr. Lopez has just mentioned to you. So I guess what I'm going to do is talk a little bit about some of these decisions very briefly and hope we can get back to them in the Q&A. The first decision is traditional Medicare versus Medicare Advantage. Lots of people are drawn to Medicare Advantage because, for several reasons. One, they don't require, in fact, you can't even get a supplement to Medicare Advantage, and many of the plans are zero premium. You just pay your Part B premium. They also offer extra benefits, and everybody loves a little extra something like dental and vision, and increasingly debit cards, which is like cash on hand, which you can take to the drugstore. They're also heavily marketed. So people see this, and people with limited incomes may feel they can't afford to ask all those levels of questions that you just heard about. They don't want to pay, they can't afford the supplemental premium that people often have to pay in traditional Medicare. So that's a draw to Medicare Advantage. The big draw to traditional Medicare is, boy, you can choose whatever, virtually any doctor or hospital if they have an open, if they have an open practice. There's not a lot of prior authorization issues for traditional Medicare. And if you have Medigap, you probably have the best protection you can possibly have because you don't pay cost sharing for most of your Medicare covered services. So that's a real draw, and you don't have the hassle of prior authorization that you do have in most Medicare Advantage plans. Medicare Advantage, you got to think about a lot of different things when you're choosing. The average beneficiary is a choice of more than 30 Medicare Advantage drug plans, and they vary. They vary on covered benefits, covered cost sharing, extra benefits, the drugs that they cover. People rarely pay attention to that because they're focused on premiums and deductibles, and then getting down to all the other layers is kind of hard. Karen and I have both worked on studies looking at provider networks, and it's really hard to see whether doctors are in your network, that you're specialists. It takes a lot of legwork to do that. And as people grow older and get sicker, or maybe have cognitive impairments, which really nearly 20% do, that becomes a big challenge. We looked at prior authorizations. We found 46 million prior authorization requests for Medicare Advantage plans in 2022. Now, maybe they help to screen out inappropriate care, but we know that adds a burden to oncologists and other healthcare providers and delays coverage and care. So my point is, and I want to turn it over to Karen, that there are opportunities to make a decision, and people like choice, but these choices are not easy. They add a burden for beneficiaries and their families, and there are consequences to making an unfortunate choice. And so this is a great time to rethink those options and also contact state health insurance assistance programs that can provide help.
Thank you. I'll turn it over to Karen.
Thank you, Shelley, and for convening this webinar, and thanks also to Tricia and Dr. Lopez for their wise remarks. I'm going to try to give a brief overview of the health insurance options that people have before they're eligible for Medicare. I've recently retired, but I spent my career studying this coverage. And as a cancer survivor myself, some of what I know I learned the hard way. So I'll start with job-based coverage, which Shelley mentioned. That's where most people under 65 get their insurance, health benefits through their own job or that of a family member. There are literally millions of job-based health plans in America, so I can't go through all of the differences. In general, employer-sponsored coverage is pretty good. It's pretty comprehensive. In general, it has broad networks of participating physicians and hospitals that you can see. In general, the premiums are also pretty affordable because employers usually pay most of the premium for you, although that's not always the case. Cost sharing, though, under job-based plans can be really high. In fact, it's getting really high. The average deductible in an employer plan now is about $1,700 per year per person. And not all employer plans are good. Some employers offer kind of crummy bare bones plans. So just the one thing I'll say about employer-sponsored coverage is that it is worth exploring any group benefits that you may be eligible for, and that includes COBRA if you've recently lost your job-based coverage or if you anticipate losing it soon. COBRA is the federal law that lets you stay in your group health plan even after you've otherwise lost eligibility. It's really expensive because the employer no longer has to contribute to the premium, but if your job-based coverage has been working for you and you're a cancer patient or survivor, it covers your docs, it's been paying your claims, not a lot of hassles, it's really worth looking into it. And if there's any way you can swing the cost, consider that. If you're not eligible for coverage through a job and you're not yet ready for Medicare, then you need to go to the marketplace in your state. Healthcare.gov is the marketplace in most states. The federal government runs that for most of the states, but about 18 states have their own marketplace. They have different websites, but if you go to healthcare.gov and put in your zip code, it'll tell you your state's website. And when you go to the website, that's where you'll see the other two main sources of coverage that you should be looking at if you're under 65. The first one of those is Medicaid. And for kids, there's also the Children's Health Insurance Program. Sometimes that's a separate program in a state. This is a public program for people with low income. About 60 million non-elderly Americans are currently covered by Medicaid and CHIP. In most states, adults are eligible just if they have low income. People are often surprised to find that they're eligible for Medicaid because they think still the ACA changed this, but they think that, you know, this is a program that only comes with welfare benefits, cash benefits. And the ACA changed that, at least in most states. So now it's just if you have low income. So even if you, recently, had a job that paid $100,000 a year and you lost it, in most states, you're eligible for Medicaid if your current income is low, and zero would be low. Importantly, states got to choose whether they would adopt this Medicaid expansion. 10 states did not. Texas, Georgia, Florida. They're mostly in the South and in the West. And in these states, Medicaid still is tied to eligibility for cash welfare benefits. So if you're an adult and you're not disabled and you don't have dependent children and you don't have any income, in those 10 states, you still can't get Medicaid. But look at Medicaid, fill out the application in the marketplace, because if that's available to you, it's open for enrollment all year long, not just during an open enrollment period. There are no premiums. There's no cost sharing, maybe tiny, $2 visit copays, but, comprehensive benefits. So really consider Medicaid. And then if you're not eligible for Medicaid or employer-sponsored coverage, when you go to the marketplace, you'll fill out the same application, but then you'll be looking at private health insurance, private non-group health insurance. And about 20 million people in America do this. And before the ACA, this is not a market that was open to cancer survivors because our health history was a pre-existing condition that would get you turned down. So the ACA changed a lot of things about the private non-group market for the better. It doesn't discriminate anymore. It has to cover essential health benefits. And importantly, the federal government provides subsidies, income-based subsidies on a sliding scale to make the premiums and the cost sharing more affordable. And those are all great changes, but this market still has a lot of problems, I just have to say. And so there's stuff that you need to look out for, although you can't always fix it. First of all, just in terms of signing up, you can only sign up for private coverage in the marketplace during open enrollment. That starts in 2 weeks on November 1st. In most states, it goes through mid-January. In some of the state-run marketplaces, it goes all the way to the end of January. But that's when you can sign up for coverage for the 2025 coverage year. Outside of open enrollment, you can also sign up, but only if you had a qualifying life event, like you lost your other coverage because you lost your job or through divorce or something like that. Something else you'll notice in the marketplace, all of the private plans are described with metal levels, bronze, silver, gold. Sometimes you'll see platinum, not often, and that signals the overall amount of cost sharing that you'll encounter in that plan, deductibles, copays, and so forth. I'll come back to that in a minute, but pay attention to the metal level. Premiums for marketplace plans are really high. On average, a silver plan, that's kind of the benchmark level plan for a young adult, is going to cost about $400 a month. And if you're in your 60s, it's going to be over $1,000 a month on average. However, almost everybody who comes to the marketplace qualifies for premium subsidies based on your income. Those are called premium tax credits. When you fill out your application and enter your income, the marketplace will tell you how much premium tax credit you qualify for, and it'll show you the net premiums after that subsidy has been taken into account. Cost sharing in marketplace plans is super high, way too high. On average, the annual deductible per person per year in a bronze plan is over $7,000. In a silver plan, it's over $5,000. Even in gold plans, over $1,000. So there's some great inflation going on here in these metal levels. And then once you've met the deductible, you continue to pay copays and coinsurance and other portions of the cost of covered care until you've met your out-of-pocket limit, which is over $9,000 a year in 2025. Also, the cost sharing in marketplace plans, it's not so intuitive. For example, even in the bronze level plans, you'll find a lot of zero deductible plans. It's like amazing. Oh, and those are the cheapest plans. How great. But they've tucked that cost sharing someplace else. In the resources that Shelley is making available on her website after this, you'll see an example of a zero deductible bronze plan that requires a copay of $150 per outpatient doctor visit, $100 to $500 copay per prescription refill, $1,500 a day copay when you're in the hospital, plus another $400 copay every time a doctor comes to your bedside in the hospital, $2,000 copay for emergency room visits. So don't just look at the summary information that you see on the landing screen for Healthcare.gov about the cost sharing. You really have to dig into the details. To do this, there's a document. So look for this document. It's called the Summary of Benefits and Coverage. It's a standardized summary. Every plan has to have it. Employer plans too. It's an 8-page chart, black and white print with blue borders. And there's an example of that in Shelley's resource page. But that will show you all of the covered essential health benefits and what the cost sharing is for each category, both in and out of network. On that SBC, you should also find a link to the formulary that explains how drugs are covered under this plan and how much copay and other cost sharing will apply for your drugs. Something else about marketplace plans, the provider networks, Tricia mentioned this for Medicare Advantage plans, that they're narrow. In the marketplace, they are seriously narrow. On average, a study that we finished just as I was leaving KFF found that marketplace policies exclude 60% of the physicians in the plan service area. Now, some plans have broader networks, like they might cover 75% of the area physicians, but some are narrower. In Chicago, where my daughter lives, the average marketplace plan excludes 80% of the doctors in Cook County. So there's a really wide range of network sizes and breadth in the marketplace. They all kind of skew narrow, but the marketplace doesn't give you any clue. Oh, this is a narrow network plan. This is broad. This is medium. The best you can do is click into each plan's provider directory and research all the doctors and hospitals that you care about, see if they're in there. And even if you find the name, you need to call and confirm that they're in network, because these provider directories are notoriously not up to date and full of inaccuracies. Just a couple of other tips for signing up in the marketplace: start early. Open enrollment starts November 1st. Don't wait until Christmas Eve to start. This is going to take some time. In most areas, you're going to find that you have more than 100 plan choices. And as Dr. Lopez says, you can't just sort by premium and pick the cheap premium, because all this other stuff is going to be going on. Narrow networks, high cost sharing, that will more than eat up in your out-of-pocket costs what you just saved in premiums. Study the cost sharing details in the formulary, find that summary of benefits coverage, and really go through it. And also, you're going to need some time just to complete the application. For some people, this is very straightforward, but it can be complicated. It's going to ask you questions about your income and your family status, and whether you have access to job-based coverage, your citizenship. As you get ready to start the application, look up your Social Security number if you don't know it. Have on hand the care needs that you anticipate, like Dr. Lopez described. Get your most recently filed tax return. For most people, that's going to be your 2023 return that you filed this spring. The marketplace is going to start by asking what your adjusted gross income was, and it's going to base your subsidies, your premium subsidies and your cost sharing subsidies based on that. But if it changed, which will be true for a lot of people because they're coming into this weird place, then you should have other documentation showing how your income has changed. And then you can get the marketplace to adjust your subsidies to reflect that. Ask for help. Don't feel like you need to be brave and do this all on your own. Every marketplace has a navigator program that offers free help with the application and with enrollment. These navigators are trained professionals. They know the ins and outs of the application, both for the private plans and for Medicaid. They can help you compare plans. They won't charge you anything, and they won't try to sell you anything. A lot of people also go to private insurance brokers for help, which is fine, and they're also very smart and helpful, but they are paid by the insurance company for signing you up. So if you're concerned that maybe you want a second opinion, get it. And then once you've signed up for coverage, whether it's in the marketplace plan or a private plan through an employer, lots of times people encounter problems, especially if they're sick. A recent Kaiser survey found that most insured consumers experience problems with their coverage once they get it. And among people with health conditions, including cancer survivorship, 2/3 experience problems. Those can be really complicated, as Dr. Lopez mentioned. Don't take no for an answer. That's my advice, and ask for help fixing that. None of this is easy, and so I'm just going to close with a word about advocacy, your own advocacy. If something pisses you off about your insurance, let somebody, who you elected know about that, and let the NCCS know. I mean, it's really important for patient organizations to stand up. And the problems that people encounter in health insurance today, in my informed opinion, shouldn't be happening. End of story. They shouldn't be happening. Insurance needs to work better. It needs to be simpler to sign up for, harder to lose, and it needs to actually connect people to care that they need without a lot of hassles and without thousands of dollars in high out-of-pocket costs. The barometer that we use to evaluate health insurance has to be how well it works for cancer patients and survivors and other people who really need to use their coverage. Just like we crash test cars to make sure they meet safety standards, policymakers should be kicking the tires on health insurance, see how it works, see where it doesn't work, and where it isn't working, fix it. The good news is there's a lot of tools for policymakers to do this. The bad news is they don't use them all and they haven't even implemented all of them. But there are transparency laws. The ACA is required now for 14 years that health plans report data on how often they deny claims, how often care is out of network, how often they require pre-authorization and grant or deny that. This is mostly not happening. It's not happening at all for job-based insurance and just a little smidgen of it in the marketplace plans. That should be happening all over the place, and how reliably plans connect you to care. There should be measures for that, and it should be prominently displayed on every plan. The federal law also has network standards. They say that marketplace networks have to be adequate, and yet Chicago plans on average exclude 80% of the doctors. So those laws need to be implemented in a more meaningful way, and they really need to be enforced. And when you run into trouble, the federal law also established something called the Consumer Assistance Program, CAPS. They're supposed to be in every state. They were established back in 2014, but Congress hasn't appropriated any money for consumer assistance programs since 2014. So those programs need to be fully funded. They need like a couple $100 million a year. That's my estimate, so that they can be everywhere and they can be staffed with smart lawyers who know how to advocate for you and go after your plan and fix the problems when you have them. That sounds like a lot of money, but actually just a little assessment, like $1 or $2 per covered life per insurance plan per year, would more than adequately fund these programs. So I have other things on my wish list too, but I'm going to shut up. I've gone over my 5 minutes, and am happy to hear your questions and hear the rest of the discussion.
Thank you, everyone, all of you, for your comments. And this is Karen, unplugged from no longer being a KFF employee and is now an advocate. So we're going to work with you to try to address some of these issues. So I have a ton of questions from the audience that were submitted ahead of time and during, and things that I have. So I'm going to try to get to as many as possible. I think what we can do is also go back, and ones we don't get to, we can post on our website. So I want to start with Medicare versus Medicare Advantage. And Trish, you already talked about this a little bit, but there's a bunch of questions, and I'm going to kind of combine some questions. But people saying that they are hearing that Medicare Advantage is not great for cancer because a lot of big cancer hospitals don't accept it. So can you? So I wanted to see if you can address the network issues, also the switching between if you started with a Medicare Advantage plan. So I got a question from an advocate who had a Medicare Advantage plan that he was happy with for a number of years. He's post-treatment, but he found out he was getting dropped from that plan. So what happens if you get dropped? You would have to, can you get Medigap plans if you switch to traditional Medicare? And then also another question about, all these benefits that are happening with the Medicare Advantage plans. Are those things, that people really need? Some people really do need them, but you could also, people said that they could use those plans, those benefits in terms of a better coverage instead of all these extra benefits. So that's a bunch of questions in one, but maybe you can go into a little bit more detail on that.
Yes, happy to do that. And also gratitude for Karen for raising a bunch of issues that apply across markets that really do require and would benefit from advocacy from the community. Okay, let me just sort of take what, your questions as they came. One was about networks, and we are continuing to look at provider networks. We did a study a while ago that showed the share of plans that did not have an NCI cancer center, when there was one in the area that was in the network, We are going back to look at that, but I think, again, this is an issue that consumers really need to look at. There are press reports, and I get calls from reporters now fairly frequently when they are hearing about provider groups that are dropping out of network. Scripps Medical Group in Southern California got a lot of attention when they said, we're done with Medicare Advantage, because they were denying claims, delaying payments. It was less to do with the amount of payment and more about the hassle factor. And they said, we are done. There are something like 28 groups that have now said we're done. This is something that we are hearing more and more about from providers. So I think this is something that people need to pay a lot of attention to, in order to be sure that if they're seeing a specialist, they can actually see that specialist. And if there's a convenient place where they're getting their chemo, they can go to that place in their network. That turns out to be a big issue for people. So yes, you got to be on the lookout for provider networks, to your first question, because that is a real issue. Second, it has to do with switching. There's been a fair number of press reports about destabilization in the market and plans terminating the market, leaving people high and dry. The one thing I want to say is those reports are a bit misleading. They come from industry sources that don't like some of the changes that CMS has made in terms of payment policy, which were not very dramatic. In truth, the average person still has a choice of more than 30 Medicare Advantage plans with drug coverage. So this exodus is not happening. That said, some plans are terminating. They are in the market to make money. That is why they are participating in Medicare Advantage. So if they can't profit, they may terminate. If that occurs, if the plan has another plan in the service area, they might switch somebody. If they don't have someone in the service area, a person in a terminated plan could choose to go to another Medicare Advantage plan if they want. Or they can decide to go to traditional Medicare. And sort of one benefit, if you could call it a silver lining, of being in a plan that terminates coverage is that means when you go to traditional Medicare, you have a one-time guarantee issue protection. You can sign up for a Medigap policy. So let me back up with this Medigap thing, because I know it's a little bit confusing. Medigap are these supplements to traditional Medicare. And something like 12 million people in traditional Medicare do have a Medigap supplemental plan. But for people who've been in Medicare Advantage for years and decide to switch to traditional Medicare, they can be denied coverage or charged higher premiums if they have a pre-existing condition. This, by the way, is an issue that could benefit from some advocacy, because it's one of the very few health insurance products that still allow pre-existing condition exclusions and premium increases that would affect a lot of people. And I will say we're putting out a report this week, possibly today or tomorrow, on Medigap guarantee issues, like the kinds of conditions. Karen, you'll remember you did a study that looked at potentially deniable conditions. Well, they are back in the Medigap market. So having a plan terminate coverage is kind of good for people who want to go to traditional Medicare, because they can get this coverage. Extra benefits. Extra benefits are sweet. It's always good to get an extra benefit. But if you have a serious condition, some vision, like a pair of eyeglasses, or some amount of money toward dental, which may or may not be expensive dental things that you worry about, but more like preventive cleanings, may not be the most important thing in the world to you if you need treatment for your medical condition. So I would say extra benefits are great for people who don't have other worries, but they would not be my first worry. If I wanted to go to if I wanted to go see Dr. Lopez for my condition, I would be looking at a Medicare Advantage. I would probably be in traditional Medicare, but many people, if they choose Medicare Advantage, I would check that network really carefully. The last thing I want to say is lack of transparency still is an issue with Medicare Advantage. One of the things that you cannot find, because this information is neither collected nor reported, is prior authorization requests and denials by type of service. I don't know, excuse me, why CMS doesn't collect this information, but I think consumers are entitled to this information because it really does matter. It affects your decision making. It is as important potentially as cost sharing for a certain benefit, whether or not an insurer tends to require lots of prior authorization, let's say for post-acute home health care, for any kind of service. So there are a lot of things to look out for in making these decisions.
And so for the prior authorization, that's really an issue in Medicare Advantage, not in traditional Medicare.
That is correct.
Okay.
But unfortunately, I heard Dr. Lopez say, like, look into this if you can, because it really is an issue. And it really is an issue. But unless the federal government collects and reports this information in a way that consumers can use it, it's really, really hard to find out how this would be applied by any given insurer and what this might mean for your care.
And so if you have if you're not in a Medicare Advantage, but prior authorization is also used in employer sponsored plans and in other plans, is there any way to know when you're selecting a plan, like the degree to which they use prior authorization, or that's what you're saying, they don't really collect and report that information?
Yeah, so they don't collect that information at all from employer plans. The federal government is beginning to collect a smidgen of it from marketplace plans only in the Healthcare.gov states, but no detail. So you can't tell if these pre-auth rules are for cancer care or for cardiac care or for MS. You can't tell what it's for or how often it's approved. If you want to, again, like hunt and peck and begin to dig, go back to that SBC. In addition to the cost sharing information, the third column on the right-hand side is supposed to include kind of limits on coverage. So it should mention something about prior authorization, but it'll only be very general. And if you click into the formulary, hopefully that will include information about whether prior authorization is required for certain meds, but I don't know. I don't think anybody looks at that. Nobody conducts any oversight on the accuracy of these SBCs, and I don't know how faithfully plans are providing that information. So it's mostly a mystery in the private insurance world too, but it's not supposed to be. By law, this should be out there for everybody to see, and you should just get scores on all this stuff. This plan, on average, last year denied 10% of claims. This plan denied 30% of claims. This plan denied 10% of cancer claims, right? You should have that level of detail. And if you had it, I think the plans would behave better because they wouldn't like seeing those numbers out there, especially if they're an outlier.
Dr. Lopez, I think you wanted to add something.
Yeah, my only comment was that the information would be really helpful, but the reason I think that it might be helpful also is that clinicians say it's like you were saying, Tricia, scripts saying, I can't deal with it anymore. And I think it just may limit the number of people that are on a plan if there's a big hassle factor.
Mm-hmm.
And that's important because people often want to stay with their doctors. And then, people work as a team. So if I normally use this radiology group, and now you're going to be on a plan that's going to force me to use this other group, it really is hard to get those reports. I mean, I know there's this illusion that it's all electronically and all digital and it's in the computer, but the fact that it's in the computer, to me, it's like, it's a black box. I still have to go and hunt for it.
Okay, now I'd like to turn to Part D, the Medicare prescription drug benefit. And there's some changes to it this year that are really important. And I'm wondering, Tricia, if you could talk about those changes, the kind of additional patient protections that were added as part of a Part D plan. And how, when you're choosing that, can you keep your Medicare health plan and change your Part D plan during open enrollment?
Thank you for that question, Shelley. I'm very excited about this one change that is in the Inflation Reduction Act that most people do not know about according to our polling. Starting in 2025, Medicare will provide a $2,000 out-of-pocket cap on drugs that are covered under Medicare Part D. This is really a great thing. I'm just going to use my sister who had ovarian cancer as an example. She had a Part D plan. She was paying $13,000 out of pocket for her cancer drug when she's no longer with us, but had she been alive in 2025, if she were still alive, her annual out-of-pocket cost would go from $13,000 to $2,000 for not just this drug, but all the drugs that she takes. So this is something that is a really big deal that I hope oncologists will know about and others will know about and patients will be happy to hear about because it's a big change that's coming their way. In terms of choosing Part D coverage, I can't remember, Shelley, exactly, was that your question? People do have, when people are choosing their Medicare Advantage plan, they tend to look at premiums and extra benefits. They tend not to focus on drugs. So I think if you are in the Medicare Advantage world, it is really important to also look at drug coverage. If you are in traditional Medicare and you also will have a choice of more than 20 different standalone drug plans on average, it's also important. And here's actually where the government website, Medicare.gov, is really helpful because if you can force yourself to do it, you can enter in all your drugs, you can enter in the doses, the preferred pharmacy, and it will give you your expected out-of-pocket costs, and it will tell you if the drugs are subject to prior auth or other cost management tools. So still a lot of people don't go through the process, but if they do, they can get good information to help cover their costs. And there's the backstop of the $2,000 out-of-pocket cap, which thrills me to pieces. And while we're talking about out-of-pocket caps, I just want to toss out another issue, which is this cap does not apply to drugs covered under Part B, as in, boy, these are drugs administered by physicians. So there's an out-of-pocket cap on the drugs you buy from the pharmacy, but no out-of-pocket cap on Part B drugs, which exposes people to, 20% coinsurance and high out-of-pocket costs.
And the out-of-pocket cap only applies to drugs that are covered. So it is important that when you're selecting a plan, you check to make sure that the drugs you need are covered under that plan.
Absolutely.
What happens though if the drug is on the formulary, and then it gets changed or changes tiers after the new year starts? So you think you've chosen a plan that's going to cover you and then it changes.
Shelley, that is a great question. And I am not entirely sure. I'm just going to say I'm not entirely sure of the answer. First of all, your doctor can appeal the decision. Your doctor can kind of push back and file an appeal, and that is sort of the first line of attack. I have not heard of many cases where this has happened, so that's something I can look into.
And cancer patients do have some protection with drugs being covered because of the 6 protected classes. Can you explain that a little bit?
Yeah, the underlying law includes the 6 protected classes, one of which is neoplastics, which are drugs for cancer. But their cancer patients also take other drugs, which may not be in one of the 6 protected classes. And drug plans have flexibility in what goes on and on, not only what goes on and off their formulary, but on what tier they put it. And tiering really matters because that affects cost sharing. And while I've been going on about my appreciation for the out-of-pocket cap, still, if you're paying a 33% coinsurance, or in some non-preferred cases, a 50% coinsurance, you're going to get to that out-of-pocket cap pretty quickly. And you still might walk away from the pharmacy if you go to the pharmacy and they say, well, that's going to be, $500. People may decide not to take a drug that was prescribed because they can't afford it.
Yeah, and in fact, a lot of pharmacists will say that's going to be $500. Do you want to fill it?
Yes.
And
Yes.
people need to fill it, but they know that so many people cannot fill
Now,
it.
there is a provision in the law that helps people spread the costs over the course of the year. And that is something, if anybody goes to the pharmacy and gets hit with a really high bill, there are ways to spread the costs over the course of the year. So that's something that everybody should take a look, really ask about, walk away from the pharmacy and go without a drug your doctor orders.
Right. It's called a Medicare prescription payment program. And we do have a link on or we have some information on our website about it. It is, I don't think a lot of people know about it. I happen to just, N of one, I asked my pharmacist, do you have materials that you're sharing with people about this? She had no idea what I was talking about. I actually printed out something that I'm going to take into her today so that she knows about it, so that she can help people. Because even if you're going to hit the $2,000 cap in January, if you want to spread that out over the year rather than paying it all in January, this program would allow you to do that, but you have to sign up for it in advance. And you have to sign up for it every year. Okay, I want to ask a question that kind of Dr. Lopez touched on when you talked about what assessing your needs, but I wanted to just kind of ask it directly and then let others comment as well. How should cancer survivors look at their changing health coverage as they move along in their survivorship journey? So should you have different coverage in years 1 and 2 than when you're post-treatment and you have different needs for your care?
That's for Dr. Lopez, right?
Yeah, I think you could start, but then I'm happy for anyone else to chime in. Sorry.
Thanks. Sorry. I was like waiting for the wisdom to come. But, um, I think that one of the, something that, again, these are things that I've seen, is sometimes it'll be like the 3-month visit or the 6-month visit. So sometime within that first year, and then I get some notice that, oh, Mrs. Smith can no longer come. And most of my examples are on women because I'm a breast oncologist. So that's most of the patients I see. But not to say anything bad about Mr. Smith, but yes. So I'll get a message, Mrs. Smith can no longer see you because because she's no longer on active treatment. Now, the person may still be getting medications, but somehow, if it's not chemotherapy, it's not considered active treatment, or radiation, I guess, that they're being transitioned to survivorship. And again, it's kind of a black box what that means. It may mean nobody at our center can see them, that they need to go somewhere else, or their primary. And so then it's some big process where we, again, make the case, try to make the argument. And what's very scary for me at that time is that maybe I gave the patient 3 months of medicine, but maybe some of those medicines are injected and they have to come in and they can't come in and have it be paid. Or they're almost at the end of that 3 months and I can't be the person that prescribes that renewal. It has to be someone else. So there can be gaps in treatment. So I think knowing how long that coverage is. And then sometimes, people, let's say they've had trastuzumab or adriamycin, and, they need to have ongoing follow-ups. And will those ongoing studies, echoes, for example, will those ongoing studies still be covered? Because again, sometimes, they're no longer on active treatment, the imaging, it all becomes a much bigger ask than what it was when the person was considered in therapy. So coverage and survivorship coverage, like what does that mean? And do people get transitioned?
I just want to say, I think this is an area that, as you called it, a black box. I think a consumer, a very, engaged consumer would have such a hard time finding out in advance if they would be able to continue to see you in a sort of a post-treatment phase. And maybe this is also an area where there's a need for sort of advocacy and identifying, what are insurers actually doing and what can be done about it. Because I just cannot even imagine going through this inquiry myself and getting good answers from an insurance company, much less a website. And it seems so important to people to be able to stick with their specialist oncologist for an extended period of time.
Yeah, to me, I mean, I turned 65 last year. Medicare sent me a card for my birthday, and I said, aha, I'm retiring. And I have to say, and I didn't sign up for Medicare Advantage. I got traditional Medicare and a Med Sup plan. Part D is a whole other story, but that's it. For the rest of my life, every doctor, every hospital in the country is covered. And if my care needs change or I get another cancer, a different kind, it's covered. I mean, that I don't have to worry about those changes. All other coverage, whether it's job-based or the marketplace, um, it's like buying your toothpaste one squeeze at a time, and you don't know how it's going to change. Your coverage can change over time. I mean, how weird. You squeeze your first toothpaste squeeze and it comes out white and the next one comes out green. It's like, what happened? But insurance can change on you and your needs can change. So our whole kind of system is a little screwed up in that people are it's set up to fail just when you need it the most. When I was first diagnosed with cancer, my daughter, who's 30, she was in diapers. I had no idea that was in my future that year. It never would have occurred to me to even look into it. So, and if you're in a plan with a narrow network or a small formulary, that can catch you. So we shouldn't be treating consumers, right, like they're shopping for oranges or shoes. You don't know what your care needs are going to be. You just know that you want to be healthy. And when you get sick, whatever happens, you want to be able to get the care that you need. And we need to look for ways to change a lot of our health insurance, including Medicare Advantage and the marketplace, so that you know, so that you don't keep encountering those missteps.
So there's a question that about Medigap plans, how to choose the best Medigap plan. Do you have advice on that? And is that also on Medicare.gov, or is there other places you go?
Yes, I mean, Medigap is a lot easier in that Medigap fills in cost sharing. So Medigap's not making decisions about what doctors you see. Medigap's not making decisions about whether your care is appropriate and requiring you to go through hoops. If Medicare pays for it, Medigap wraps around it. There's information about Medigap on Medicare.gov. There are also the state health insurance counselors can tell you who are the carriers in your area or who are the national carriers. And there are standard plans. So when you're comparing plans, there's not a lot of, there aren't a lot of bells and whistles in terms of extra stuff. You can, and they're lettered, A, B, C, D, E, F, G kind of thing. The most comprehensive is Plan G, and every Plan G offered by any insurer covers the exact same cost-sharing benefit package. So that makes it really easy to go, I'm going to compare this insurer to that insurer for Plan G, and I know the way premiums are rated in my state, and I'm going to choose the lower premium. It's a lot more straightforward, and there's a lot less worry about, whether they're going to deny a service or make you file more paperwork. It's really pretty seamless. The other benefit it has for people on Medicare is that the paperwork goes between Medicare and Medigap. And so people on Medicare can look at these notices like, this is not a bill, but you know that your paperwork has gone from your doctor to the government to your Medigap insurer, and that's kind of it. Which for people when they are sick or growing older is a real benefit, because while they're worrying about taking care of themselves, bills can, kind of fall through the cracks, and that can create a whole nother set of problems.
So someone asked, is Medigap different from Part D? You need both. So can you just explain?
You need both. You need both. And in fact, you don't have to get a Medigap policy, but if you're in traditional Medicare and you don't have drug coverage from another source, then you do need to get a Medigap policy. A Part D policy, I misspoke. And if it's a voluntary benefit, but in some ways that's a little bit misleading because there's a penalty if you don't sign up and you go without coverage, and then you wait until you have, drug expenses, and then you sign up. So really, if you choose traditional Medicare, you do need to have drug coverage, which is under a Part D plan. You may choose to buy Medigap policy. Part D is paid for by the federal government subsidizes Part D. It is a Medicare drug benefit administered by private insurers who get money from Medicare in combination with premiums to provide the benefit. Medigap is purely private.
And then if you get a Medicare Advantage plan that cover, you wouldn't need a Medigap or a Part D plan. The Part D is part of your Medicare Advantage plan.
That is correct. So the beauty of Medicare Advantage is it's one-stop shopping, but you would have all the cost sharing that you wouldn't have in traditional Medicare with the Medigap policy. But yes, I saw a question.
Yeah.
Like I saw the question, and yes, you do need 3 cards. You need your Medicare card, the Part D card, and your Medigap card. Nothing makes me more upset when people get confused and say, wait, I need A, B, D, and G. Like, that's crazy. And yeah, there's something to it that is a little crazy because it's unnecessarily complex.
Put that on your to-do list, Tricia. Someone should stitch traditional Medicare together and just make it all one plan.
Just like that.
Yeah, put that on your list.
I feel like we could keep going for a long time with additional questions, but we are at time, and we will do our best to try to answer a lot of the questions we didn't get to and put them on our website. I'm sorry we couldn't get to everything. Thank you, Dr. Lopez, Tricia, Karen. Really appreciate your time and your expertise. This is a really difficult subject. And can you just say one more time about the SHIPs and how that's a great place to go for help with navigating?
Yes, absolutely. Every state has a state health insurance assistance program, staffed mostly by volunteers, often associated with area agencies on aging, sometimes the state insurance commissioner's office. This is a great resource, and I think there will be a list on that you're distributing of telephone numbers in each state. These are neutral, financially disinterested experts in Medicare coverage, and a great resource for people trying to sort through what has become a really complicated insurance system.
Great. Well, thank you everyone for joining us today. Thank you to our experts for sharing your expertise. Please check our website. We have a bunch of information there, and we're going to be adding to it. We're going to take clips from this webinar. So if you don't have time to watch the whole thing, you can just go back and review some clips of it. So just check back in the next week, and we'll be adding more resources to our website as we continue through this open enrollment period. Thank you, everyone.
Good luck. Thank you.
Thank you.